Thank you, Anirudh. Thank you, and good morning, everyone. And so happy to see Dr. Atul, Mahesh, and everyone. So I'm kind of going to continue what Anirudh has said. So we already know about the basics in OCT, but two things which we have to realize are marked in red. Vascular networks are separately visualized, like you saw, superficial, deep, and maybe intermediate. And these slab boundaries are actually determined by the layer segmentation on structural OCT data. Now, what do we mean? We have the structural OCT and we put the boundaries depending on which layer we are going to study the vascular network. So this is how the superficial, intermediate is a very narrow zone, as you can see, the deep, and finally the choriocapillaries. Now you can very well understand that if by mistake you are not marking this boundary, so you will not be seeing that particular layer which you wish to. So that is one of the common mistakes one makes in OCT angio interpretation is the segmentation error. So how can you interpret it? So I'm going to show you an example. Now this is a patient of diabetic macular edema. You look at the angio OCT, you see the superficial layer has, some areas of void with increase in the intercapillary distance. But when you come to the deeper plexus, this was interpreted as area of non-perfusion with few spaces here. But this area was area of non-perfusion, and then you go on to the deeper layer where nothing much is happening. Where did we go wrong? We went wrong because you have not seen the OCT through which the segmentation lines were passing. So when you are looking at the deep layer, when we talk of the deep layer, we talk of the normal retina because the segmentation algorithm is meant for the normal retina. Here the retina has pathology, and these segmentation lines, which are supposed to be passing through normal autoplexiform layer, are passing through the cysts. So that is when you see the outer layer angiogram or OCT angio, you see these dark spots and you may interpret them as non-perfusion if you are seeing it in isolation. So it's very important that you also see NFAS OCT to see what is the pathology and B scan to see where the segmentation lines are. This is following the treatment, and you can see the cysts are reducing, and this, perfusion is kind of, you are getting it back to normal because of the reduction of the cysts. So mistake 2, which is again very common, is the projection artifact. The OCT angiolite passes through the larger superficial vessel and then goes into the deeper. So what happens is the light fluctuates because it has passed through and is altered by the moving blood cells in the superficial layer. So what you get is like this is the superficial layer, and when you look at the deep layer, there is apparent replication of the superficial vessels in the posterior layer. This problem has been sorted out largely by projection artifact removal. So that you have to make sure, and it's also important that these artifacts are more prominent in the deeper layer, which have a high signal intensity, for example, RPE. And the practical interference of that is, for example, this is a patient with a choroidal neovascular membrane, as you can see here. But if you have not removed the projection artifacts, you see the whole, jumbo of the blood vessels. And many a times you feel that these blood vessels are probably feeding the new vessels. There seems to be a communication between the superficial vessel and CNV, which is not true because it's simply because you have not applied the PAR, which is projection artifact removal. Now, this is when you apply that algorithm. It's just the click of button on your machine. You now see CNVM very clearly without any vessels coming out or draining out of it, which was erroneous. The third mistake is, and Anirudh has already spoken about it, that when you look at the OCTA and you try to make the diagnosis. For example, I show you this NFAS OCTA, and maybe you get it in your exam if you're a senior resident or whatever. So somebody asks you whatever it is. So this is NFAS of choriocapillaries angiogram. This shows there is some displacement of choroidal vessels and what mimics like a macular neovascularization. Fair enough. Is it a MNV? Now comes the role of NFAS structural image. Now, when you look at the NFAS OCT along with this OCT angio, you see an increase in the signal intensity in the atrophic area, and that is because overlying RPE has been damaged and there is increased signal to the choroids. So you know that it is not straightforward MNB. The third thing which you rely on, how much is the flow? Again, if you just look at the flow on the B scan, you will say, wow, this is what I diagnosed as macular neovascularization. It has a very high flow on OCT, so let's give injection. But no, that is because you have missed the OCT per se, B scan, which shows there is atrophy and there is increased penetration, and it is not an area of increased vascular flow as you would come up to be. So the moral of the story is that you always see four of image display, never see one or the other in isolation. Always have OCTA NFAS, OCT NFAS to see the structural damage, B scan with flow and B scan without flow. That's how you are going to get the interpretation that might be clinically relevant to you. The fourth mistake, which is actually a very obvious mistake and you can't really miss it, is the motion artifact. So what happens, you are doing angio-OCT and the patient is move the eye, and this is called the bulk motion. So that produces a kind of linear shadow. So this kind of a linear shadow, which you see here, this is something which you all, it is on your face, to be very honest with you. So if you see these kind of motion artifacts, never rely on OCT. And what is very important, in many trials, we have not been able to include OCT angio for the quantitative measure because motion artifact is the one which is going to affect the quantification in the biggest way. And lastly is sometimes you are seeing microaneurysms, you may not be seeing it. So if you are planning really a focal treatment, especially the repeat treatment, don't go by the fluorescein OCT angio, do a fluorescein. So to conclude, OCT angio is a great tool, but it needs caution while interpreting. And you can realize it that even after so many years, we have not been able to incorporate as a part of major trials because of these issues. So be careful when you are interpreting it in your clinical practice. Thank you very much, and thank you, Anirudh.